You're listening to GB News Originals. I'm Lucy Johnston. Today we're asking why maternity care in the NHS is still in crisis after decades of warnings. Over the past 10 years, hundreds of babies and mothers have died or suffered life-altering harm as a result of botched care in NHS trusts across the country. And this has prompted the government to launch a rapid national inquiry. Health Secretary Wes Streeting recently admitted there are systematic failings going back 15 years and says families have been gaslit in their fight for answers. Baby charities Tommy's and Sans say 2,500 babies could have been saved since 2018 if NHS safety targets had been met. And an analysis of NHS figures shows the potential bill for maternity negligence in England since 2019 has reached a record to 27 billion. So now recent polling shows that almost half of women are frightened of giving birth, and 1 in 4 is delaying pregnancies due to safety fears. Joining me today is Professor James Walker. He's a professor of obstetrics and gynaecology at the University of Leeds and a national expert in patient safety. He's chaired investigations into maternity care and advised government on the issue. And we're going to ask him, why do services keep failing? What inquiries are doing to lead to change? And what's going to happen to restore public trust? Professor Walker, let's start with the starkest figures. Over the past 10 years, there's been, I think, at least 4 major independent inquiries or reviews into maternity services in trusts, and that's linked to hundreds of deaths and harm to mothers and babies. And now there's a review, a large-scale ongoing review of services in Nottingham University hospitals. What do these tragedies tell us about systematic failings and problems in maternity care?
The tragedies tell us that we are failing a group of women and their families and not giving them the best care, which we result in the best outcome for the mother and baby. I think you've got to remember the vast majority of women going through pregnancy have a very good and safe outcome. The problem we have is not the safety of the routine care, it's how we respond to problems when they occur, and the escalation of a concern to get intervention at the appropriate time to save the baby or the mother's life. And so it's a degree of assessment of need for intervention, and we've gone to a way of almost routinely intervening in situations where it's not necessary, but still not necessarily responding to intervention when it's required. And that's clear in the investigations that have been carried out over a period of time. Now, the reasons for that can be emphasised and brought out by the inquiries by showing that there is a culture problem, and culture is a very strange word, and it's difficult to describe exactly what people mean by that sometimes. But there's something wrong in the way that the care is being provided to women that allows that free-flowing collaboration between all the staff in the hospital to make sure the best outcomes occur.
So when looking at the inquiries, and I've written about this as well a number of times, so many families, many parents say that they were either dismissed or ignored and sometimes even blamed when they raised concerns. So why do you think the NHS has struggled to listen to women when things go wrong or are potentially about to go wrong?
I think that you've really highlighted the exact problem, and that is that the reason these inquiries have largely occurred is because of demands from families, because they've not been listened to, they've not been given answers to the problems that occurred with their pregnancy. And so the inquiries are not because the incidents have occurred, the inquiries have come about because families have felt they've not been given the answers they deserve, and we've let them down, and it is undoubtedly true. If that the families involved in Morecambe Bay and Shrewsbury Telford and Nottingham had been given honest answers from the beginning, it doesn't change the outcome, but at least they'll feel that they were talked to and listened to, and hopefully lessons would be learned, and we'd move forward and improve. The failure of listening to families, the failure of investigating it openly, means that people then fail to learn from these and implement change to try and stop them happening again. So it's the failure of the service to intervene and implement change, which is letting the families down again. Because most families who have a bad outcome not only want to know why it happened to them, but they also want to know, will you stop it happening to someone else? And that's, again, where we've failed.
Do you think that's echoed in other services in the NHS, or do you think it's particularly bad in maternity care, and why?
It's not particularly bad in maternity care. I think that the problems in maternity care is that, one, a bad event in maternity care is devastating to the families and the wider sort of group around the families, and also from a litigation point of view, the damage that the maternity errors make are catastrophic, and therefore the litigation is far greater than anywhere else. There's not any more cases brought for litigation in maternity than there is in any other area of medicine. It's just that the cost of the litigation in maternity is far, far higher because of the damage done.
So the Nottingham review is ongoing. I think it's the largest maternity investigation in NHS history, I think. Is, from what we know so far and what you know, how different is Nottingham? Is it another sort of chapter? Are you seeing echoes, do you think, of previous investigations?
I don't think there's any different than other cases that we've seen and other inquiries we've seen. And certainly that it's interesting that it's been quoted as the largest. It's simply the largest because the net was spread out to collect families who feel they had questions they wanted to ask from over a long period of time. So it goes back a long number of years. And I think if you actually went to virtually any hospital, you'd find, as we're now seeing, different families come together from different parts of the country are questioning sort of their events that they experienced and the lack of answers they had. So I don't think Nottingham is necessarily any different than anywhere else. They have the same culture problems, they have the same lack of listening, the same lack of escalation, etc., that we see all over the place. So it's to me, the unfortunate thing about these inquiries is they're very expensive, they take a long time, but they don't really give us new information that we don't already know. I'd much rather the money was spent on implementing change to improve outcome, to stop them happening. And that's the way to make things better for everybody and to take away the fear that people have now about having a baby. And one of the things about inquiries and the publicity from it, that increases and amplifies the fear that women have about having their baby. So therefore, they're not necessarily helpful from the point of view of improving the service ongoing. I think they're very important for giving families answers they've never got before, and they weren't given the answers at the time. So inquiries do give them the voice and do give them the answers they want. But it doesn't actually move anything forward because nothing changes from them.
So, yeah, you said many times these national inquiries, really expensive, really burdensome, rarely tell us anything new. But why is that? Why are we still repeating the same mistakes when we know from the findings of the inquiry what mistakes are happening? Why do these keep carrying on?
Well, the problem we have is that maternity, in fact, compared with most parts of medicine, has a very good reporting of errors and reporting of problems. The maternal mortality reports, for instance, go back now about 70, 80 years. So we've questioned what we've done. The problem is that bringing out the figures of this is what happened doesn't actually tell us what to do about it. And if you look at the changes that occurred in in maternal mortality changes and changes of treatment, it's often led by individuals who have a particular interest in trying to improve the outcomes. By improving care packages, guidelines, etc. And there's a good example of that is preeclampsia, which has been very greatly improved in the outcome in this country because of the improvements of guidelines produced on the result of the maternal mortality statistics. But you need that sort of, okay, that's the problem, where's the solution? And it's that inability to link that together, because the people who find out the problems and analyze the problems are not the best people to provide the solutions. You need different people to look at it in a different way. And there's no funding for that. I mean, people are told, you have a problem. Like CQC will go into a unit and say you require improvement, but they don't tell them how to do it.
Yeah, the watchdog, yeah. So, I mean, many people in the NHS say, well, we haven't got enough money, we haven't got enough staff. Is it about money and staffing, or is it about culture? I mean, you're
Well, I
saying
think,
that we're not. You don't think that's a big issue?
well, I mean, I think that we keep pouring more money into health services, and particularly into maternity services. We keep on being told we have more midwives and we have more doctors, but what are they doing? I mean, I'm not questioning that there is more, but in fact, we're employing more people to almost to do the checks and balances, not to actually go and improve and innovate. And so therefore, the funding needs to be directed to the right place. So I think there should be a national task force for innovation and improvement, and by taking up these problems either individually or different parts of the country take on a certain problem and look to see how will we improve that. If we have a problem with our maternity triage, for instance, because we're not catering for certain people coming through it, why is that, and how do we change the process to make sure that these things don't happen again? And we should be looking at not trying to review the bad things that happened, but actually make sure that maternity is safe for everyone moving forward. And that's by looking at the underlying causes of these events. It's not the midwife who was the last person to see the woman that's the problem. They may have not made the right decision, but on the other hand, it's based on the environment she works in, the care that person got up till that time, etc., etc. So there's a whole system of problems lead up to the events that occur. Until we understand that and we actually start putting methods that are changing that system, then we will carry on making the same mistakes. Culture is, it's difficult to know what culture means when we talk about culture, but culture is about wanting to make things better and to constantly question yourself about how could I have made things better today? And how could I have performed that in a better way? How could I communicate with this woman and her family in a better way? Just constantly questioning that and having that feeling that that's your important thing that you do, not to try and justify what you did because of what the guidelines said or what your experience was. It's about how do I make it better.
So you're calling for a national task force for improvements in maternity care, not improvements in the NHS, just to be clear.
Well, I'm obviously interested in maternity. That's my area of preference. But I'm not saying I'm not saying that it shouldn't be done elsewhere. What I'm saying is that I'd like to see it in maternity. And at the moment, more money is spent on litigation payout than is spent on caring for the women in pregnancy. It's ridiculous. I mean, so therefore we should be looking at, if you want to look at it from purely a financial basis, actually improving the outcome for pregnant women and their babies will save the health service a lot of money. And although shouldn't be the driving force, it's certainly a way of justifying it. But what we should be doing is making care safer. But that's true everywhere in the NHS.
So alongside the sort of scandals and the heartbreak and the tragedies, there's some polling that we've talked about, you and I, showing that almost half of women are now afraid of giving birth and 1 in 4 are delaying pregnancy. And that's been linked to fear and the inquiries. Do you think that that is what does that say about confidence in the system, and and about our fertility rate, which is now a record low, and what that means for our society?
Well, I think there are multiple factors to this. I don't think it's just because of the fear of the safety of maternity, although I think that is an increasing concern amongst the population. But lots of countries throughout the world have fertility rates as low as we have, and I'm not an expert in the area, but generally that's a problem from the point of view we need young people coming into the population to work and pay taxes, to look after old people like me in our adult age, and society needs that. So therefore, if we don't have that population turnover, then that's a problem for our society. But I think that the sad thing is that why do people have this fear and have reluctance to have babies? As I say, more than 95% of women will go through pregnancy with no problem whatsoever. There may be aspects of the care they were given and how pleasant the experience might be, but from a safety point of view, that the vast majority of women and their babies come out well at the end of it. These are tragic but relatively unusual events that occur, and we handle them badly. We don't communicate with the families that have suffered from the problem, and also these inquiries, though, have amplified these as a major problem far more than in reality the actual incidences. Not to demean the problems, but it's not as great as people state it is.
At the same time, we've had successive governments who have promised to make maternity care safer. We had the Better Births Review in 2016 and Labour's new pledges. But maternal deaths are they not their highest in decades? So is there a failure of political leadership in this?
Well, the figures are higher, but they haven't really changed very much from if you go back over several decades. The numbers are still very small, but they haven't improved, and we certainly lag behind other countries that have lower figures than us.
Hello, I'm Bev Turner. Now, it can feel like the money in our bank accounts at the moment does not keep up with the cost of living, and maybe there's a solution. I'm here today with the CEO of TallyMoney, Cameron Parry. Cameron, what is TallyMoney?
Well, Bev, with TallyMoney, you get a current account and a debit card, but instead of pounds, you use milligrams of gold as your everyday money.
So why gold?
Gold traditionally is a great store of value. It has, on average, gone up at over 11% per annum for the last 25 years against the pound. It's tripled in value in the last decade, and in the last 2 years alone, it's increased by 50% against the pound. Banks' savings products just can't compete with that level of growth.
But this isn't just about gold. This is about a currency that you guys have created at TallyMoney. Explain it to me as though I'm an idiot.
So, look, people need to be able to hold their earnings and build their savings in a money that retains its value and remains in their legal control and remains theirs to access, away from government control.
Great. You had me at not exposed to government control.
You should feel safe and happy with your money. You should have peace of mind the more money you see in your bank balance, and that's the type of thing we're trying to deliver, and give people choice in the type of money they get to use every day.
Brilliant. Thank you so much, Cameron. Thank you.
The problem that I've worked with various secretaries of states over the years who all come in thinking they're going to solve the problem in NHS and particularly maternity, and they bring in plans and so on. Now, the thing is that one of the problems is instead of building on what's good that we've got, they often actually strip away everything and reorganize, which in fact just means that it takes time for the health service and the maternity particularly to actually reform back to a functional unit after every change that's made. So people believe they've got the answer for it, but in reality they realize it's actually a lot more complicated than they thought. The other problem they have is they have a lot of voices that talk to them about what the problems are and what should be done. And to some extent, the problems occur because of who's got the loudest voices, and that drives a lot of the agenda, even though that's not necessarily the best way forward. And there needs to be, again, to take the heat out of it all by, as I say, producing a national task force, looking at this, involving all the relevant groups, who to talk about how do we move this forward and how do we improve things for the good of everybody. And it can't be driven down by law or from above. It's got to be brought up from the grassroots of developing the service, the people that work in the service, the people that use the service, and to actually work out what's going wrong and how it can be improved.
So the top-down approaches or suggestions, have you got any couple of examples that were really things that were clearly not going to work or clearly didn't work? Just some things that we can kind of imagine tried to be done.
The problem is that a lot of the top-down things produce instructions of what people should do, and it could be the saving babies' life care bundles or other initiatives that people brought forward and said, you must do this, you must have that. Now, the problem of doing that...
about what to do if there's a fetal distress or a heart, just sort of
yes.
in the moment. Yeah, so new regulations and guidelines just based on things that have gone wrong. Yeah, is that what you mean?
Yeah, to some extent, but also when they say that you must make sure 95% of your staff are trained in this every year. Now, the problem of that is that just puts people through seats on chairs. It doesn't actually prove that they're competent in what they do. And so therefore, it's about trying to work out what went wrong and how can we improve it, not what went wrong and what rules can we bring in to try and show that we're doing something. And so that and the problem of goals and tasks and targets that's set, that then drives the care. So you ignore all the other care to make sure you've reached your targets, because that's what you're judged on. And so therefore, what we should be doing is saying, well, let's ignore all these things. Let's make the care better. And the target then follow that. You know, the targets will be will get better. It's like I remember at a meeting of some years ago, the King's Fund, when I was asked to talk about cesarean section rates, because in Leeds at that time we'd reduced our section rate quite considerably, and what I'd said was, like, don't go and try and reduce your section rate. Go and try and make your labour ward management better, and that by definition will reduce your section rate. Don't make the target or the thing you're trying to change make the target change because you've improved the care given, and concentrate on that.
Do you think there's been an element where, because there has been a drive to reduce caesarean sections, do you think that that's sometimes led to more harm than good? Because actually the drive to give a natural birth, because of that becoming, you know, the go-to, you know, the best thing to do for the mother. Do you think that's always appropriate? Have we had a drive that was, you know, leading to harm?
There shouldn't be any sort of feeling of anything is better by definition than the other, and that's what we should be aiming for. There's no doubt from the health of the mother that a normal vaginal birth is the best outcome for the mother and baby, as long as it's the best outcome for the mother and baby. The problem comes when things are not going as normal or as well as you'd like them to, and there's a reluctance to escalate that because there's this desire to make it normal. So that from work we've done, we've shown that about 30% of mothers coming through will never ever see a doctor, need to see a doctor, because everything goes very, very well. The problem is then you've got another, say, 30-40% of people will see a doctor because maybe they need analgesia or they need some augmentation, but nothing of any great note. The midwives will be leading the births and everything will be normal and normal birth will occur. Now, these can be done if the right care is there, the right support, the right time is given to allow people to do the natural things. The problem comes when we get over concerned about what might go wrong, and we either ignore it and therefore we end up with problems we've then got to rescue, or we intervene too soon when there's actually no need to. So it's actually getting the care right using a collaborative group of people working together, not people working in silos and saying, well, we're normal birth people, so therefore we don't talk to the people that don't support us. We will support the normal birth people, but we need to be able to trust that they'll escalate it when necessary, and we will help them when necessary. And that's what we try to produce in Leeds over that period of time, and that's where we produced that reduction in our cesarean section rate, reduction of intervention, and with no worse outcome than before. But that had people working there as a team, working together, and that's the most important thing. Is that it's collaboration between the different skill groups, that we all can benefit each other. None of us are skilled to cover every area of healthcare or maternity care, but we all offer something which people may need help for. And one of the interesting things is if you look at some of the high-risk industries, like the airline industry and the oil industry, they spend the vast majority of their training on what happens when things go wrong. Whereas one of the problems with modern midwifery...
Yeah.
And,
yeah, sorry. And I suppose aircraft, when something goes wrong with a crash, you just spend a lot of time looking at what goes wrong and then how to fix it. But anyway, yeah.
No, I mean, I think that the problem is that people working in the area, the pilots and the staff in the aircraft and the people on oil rigs, the people in high risk and nuclear industry, they spend most of their training on how to respond to things going wrong, so it actually stop them going wrong. The problem within maternity is a lot of this, particularly midwifery training, is training people for normal birth, not training them what to do when things go wrong. So therefore, there's not this understanding that things go wrong very rarely, but it's important to actually have that training to know what to do. I mean, planes crash very rarely, but it's important the staff, that the pilots and the stewardesses and stewards know exactly what to do if something goes wrong, and they all work together to achieve the best outcome. That's what we should be aiming for all healthcare, and particularly including maternity.
So do you think there is an element of people working in silos? And just really briefly, what does that look like? So you've got groups that are sort of very pro natural birth, and you're suggesting that in some cases they're not happy really to work with people that are working in sort of more medicalized environments. I mean, what are the silos looking like? What do you mean by that?
Well, the silos, there are various silos. I mean, it's not just in the natural birth group against intervention group. I mean, the thing is that one of the factors for people wanting to have normal birth is the reaction against intervention. So therefore, the interventionists, if you want to call people that, they've actually driven people away from their care because they don't feel that they have the control over their own labour, control of their own bodies, etc. So it's about working together. I mean, I'm all for people supporting a given area, but they must not have barriers between that and the people who can help them if something's going wrong. And that's where the important thing is. And if you look, I wrote a chapter some years ago on home birth, planned home birth. And the centres that had planned home birth with a good outcome are all ones that are well integrated into a care provided with a local hospital environment, providing reach-out care if required. And so therefore everyone had confidence in handling the cases they had and escalating if desired. And it's the problem of lack of that escalation, slowness of response is where a lot of the problems we see in investigations come from. So it's not the philosophy of supporting normal birth, but it's the philosophy that we want to keep everyone else out.
Understood, yeah. So even this summer, Wes Streeting's launched another investigation, which I think is due to report in December. Do you think that's the right step, or do you think it's another sort of holding pattern when we actually need action, as you've talked about, pretty urgently to address the problems?
Well, the first thing is I think they probably won't report to about May, but although it was initially meant to be December, but I can't see it actually achieving that. I think that to some extent, Wes Streeting is between a rock and a hard place. I think that what he's done is that he's developed got a national inquiry going with Baroness Amos, who I think is a good choice of chair, and with getting in experts looking at what's available. By definition, what they'll do is relatively superficial because they don't have the time and energy to do everything they want to do. But I think that I suspect what they'll find is exactly what everyone else has found, and hopefully that will then lead into the next stage, which would be a task force to try and implement improvement. So yes, I think he had to do it because the pressure on him was very great from particularly families who wanted something done. But I think that it hopefully will bring another, I think, strength to the understanding that we know what's going on. Let's now do something about it.
And claims, I think, are now costing the NHS over £1 billion a year. It's the biggest share of litigation payouts in the NHS. Does that tell you something about the sort of scale of harm? And, how do we I think you've discussed this earlier, if we spent that money, how would we spend that money to improve care? What would we do if we did that upfront instead of on the compensation?
Well, first of all, you've got to remember that compensation is paid out on the basis of what private care would cost to look after the person who's been damaged. So therefore, yes, it's a measure of the damage that has occurred. It is not a measure of the number of incidents or how bad the incident necessarily is. It's about the damage that occurred from that. That's the one thing. That's why it's so great for maternity compared to, say, in other areas where they can't, other specialties can't do the damage that we do. So that's one thing. The other thing is that the problem is that it comes from a different budget than the budget for care. So you can't, although we can argue that we want to use this money to actually improve care, it's actually a different budget we're arguing against. And the other thing is that often litigation that is coming out now is on cases that occurred 8, 9, 10 years ago in pregnancy. So that therefore this is not relevant to the care is being, and any damage that's occurring at the moment is actually related to the past. So even if we took all the money away, or not, we couldn't take all the money away because it's still being paid out. So even if we improved everything and stopped all the problems occurring, there still would be a lot of litigation paid out over the next, say, 5 to 10 years before the better care is fed into the system.
Yeah, understood. And so do you think who should ultimately be accountable when improvements don't happen? So would it be the trusts? Would it be the regulators? Or would it be ministers? Or would it be sort of senior people within trusts? Who do you think needs to take
well, we're all responsible. All of us who work within the system is responsible for what happens. And the problem is a lot of the people on the shop floor really have been arguing that things should be improved and things are wrong, and this is where the whistleblowers come from, and so on. So there is a lot of unhappiness amongst the people who are working because they know they're not in a position to get a safe service and they can't do anything about it. Now, the problem then is that it's their managers then who will, to some extent, control how they respond. And the managers, of course, want to protect the hospital and protect the reputation of the hospital and so on, and don't want to be seen as another trouble hospital. But the problem is that by denying all these things, that eventually things come out through different ways, particularly from family groups who then insist that to actually get information out. So inevitably, it should be the government, because the government is the paymaster, and so that it's in a firm that fails, the board of directors are really the people who are responsible. So the government are the board of directors, and so therefore they should be looking at how do we improve things, not telling us you must improve, but how can we help to improve this by putting in the right pieces and right people and right funding to actually make a difference.
You mentioned, I think, that you might be getting in touch with Wes Streeting, is that right, about the latest inquiry that he's launched? and pointing out why it may not be leading to change. I don't know, are there things that you're doing or going to do to kind of raise some of the points we've talked about today?
I have written to West Reading and with my outline of what I feel, both the problems of another inquiry because of what I said, but the importance of actually producing a task force for improvement, and that should be the ultimate aim. And if Baroness Amos's inquiry can lead us to that, then all well and good. And another 6-9 months delay is nothing compared to the 20 years of delay that we've had in improvement. But we must start seeing improvements occurring. And I think that the other thing is that although we must listen to all the strong voices who are demanding change, we've also got to then look at it as have an umbrella view of actually what is the right bits to act on, and what bits what consensus might we have, and how would we move that forward. I'm sorry, I've just got my phone's gone. It's about listening to the right voice and getting the right people in place, and not being influenced too much by people who shout the loudest.
So just for viewers, so some may be young mothers-to-be or thinking about having a child, would you give any advice to women out there? I know you've said quite clearly it's mostly very safe, but if there is fear and people are concerned, they may be at a hospital that's got not a good record, what do you think, is there anything people can do, individuals can do, to try and ensure that they don't, that there isn't a tragedy or anything going wrong?
I think that to some extent they don't have the influence to try and stop things happening. But I think that to themselves, what I think that they can do is making sure they ask the right questions and they talk to the midwife. And if they're not comfortable with what the midwife or the doctor tells them, ask for a second opinion. And you remember that you're in charge of your maternity care, and so don't feel, if you're not being listened to, you just make sure you get someone who does listen to you. A lot of the problems and interactions with staff is actually misunderstandings rather than necessarily people trying to be difficult. But that doesn't mean that doesn't mean that the woman is not comfortable or not happy, and it's important she gets the answer she wants. And if she's concerned and she goes to the hospital and they turn her away, I think they keep pushing the concern. And that I always say that, when someone says, I feel fine in pregnancy, you shouldn't believe that, because things like high blood pressure and other things could occur when someone feels perfectly well. If someone says, I'm not happy with the way my baby's moving, or I'm not happy with the way I feel, you really listen to that. The mother knows her own body, and therefore it's important that they get listened to and people handle them accordingly. And the problem is, a lot of people will go to a hospital, they don't fit into a guideline, so people don't quite know what to do with them, rather than actually caring for them as an individual.
That's really interesting. So there's a certain set of guidance. If you go to hospital with this, do this. If you go to hospital with that, do that. But actually, what you're saying is that people are so varied, and they may describe a symptom or another. But if it doesn't fit in with the list, it may not get escalated or acted on. Is that what you mean?
That's correct. And the other thing to remember, guidelines are guidelines. They're not rules. So therefore, a given individual may not fit into the guideline. The guidelines are written on large population trials. So it doesn't mean everyone who got this treatment, who didn't get this treatment, did badly. So I think that it's about, guidance gives you some idea of what the best treatments are in given situations. It shouldn't be a guideline saying you must not do something. Guidelines usually say this is what you do if. And there may be evidence saying, in general, there's no reason why we need to intervene or treat at this point. But on the other hand, for that individual woman, it may be very important too. So you listen to the individual, you have empathy, should have empathy for that woman's feelings, and also make sure that you listen to them and she gets care accordingly. The problem we have is there's this belief that it's better for women to stay out of hospital because we don't want to put them into labour ward or into a ward and where they could be home with their families. That's great, and I'm fully supportive of that. But some women need to be there, need to be in the hospital, need to be being monitored, even for their own psychological benefit of reassurance. That needs to be provided. That's part of the care package that we should give people. To tell people you're not in labour or you don't have a problem or your baby's fine because they can hear its heartbeat, where she says it's not moving well. These are all things in which we should not be telling people what they feel is not valid. It's about listening to people and caring for them and understanding it's their concerns, their feelings, and they're feeling that there is something going wrong, which they want to be reassured about.
So, I mean, if you could make, say, three major changes right now to improve maternity safety, can you think of what they would be? I think the task force might be up there, mightn't it?
Task force is certainly up there, but I mean that's just the umbrella. I think we need to involve safety scientists who have far better idea of how people interact. I mean, one of the problems we've got, if you look at, for instance, the obstetric triage, really the problem is a lot of the areas in a building where they are run are small, they're not appropriate and not designed for the care they're providing. They don't have facilities to look after women who don't either are discharged home or admitted. The ones in the middle who they don't quite know what to do with, they don't have an ability to do that, partly because of environment, partly because of the rules in the hospital, the guidelines, etc. And therefore looking at how can we design systems which are better to care for people and allow midwives and doctors more freedom of actually caring for the individual rather than having to stick to the rules or the guidelines. Hospitals have rules about how dilated your cervix must be before you're allowed into labour ward because you're not in labour if you've not dilated your cervix to a certain point. As far as the woman's concerned, she's in labour, she's contracting, she's in pain. And to tell her that she's not in labour because she hasn't crossed some threshold, which is a non-scientific sort of decision that someone's made at some point, is just harmful because it means that she's not getting the care she deserves and doesn't understand why people are ignoring her. So the empathy, allowing people to have empathy and caring for the individual, even if that you admit more patients than you need to, even if that means that you provide extra care and attention and investigations than you need to. I mean, these are all things in which are important to make sure that all women feel that they are being looked after and and that they and their baby are as safe as possible.
I think we've pretty much covered it. I mean, I didn't know there were such thing as safety scientists, so that's new to me. Do you mean people who there are people that specialise in safety in hospitals or just generally?
No, in general, I mean, there are more in hospitals, but safety scientists, they change their name all the time. There could be used to be called human factors experts. But they changed it from that because it's not just human factors, it's actually how big your room is and where the room is compared with the labour ward is or whatever. It's about all the total environment of how, in a given instance interaction, how does everything else around affect that interaction? How does the senior person relate to the junior person and the two individuals that are looking at the care, but also what facilities do you have, what ability do you have, what's your freedom of decisions? Because a lot of times the midwives in the triage don't have the total freedom of decision. They've got to work within the guidelines and rules that they're provided. Even though they may have empathy or want to help the woman, they can't because there's no facility for them to do so. But safety scientists can come in and say, look, this is a problem here. You've got a system where you inevitably, it's what would be called a latent error. Inevitably, something will come along where that error will occur, even though it doesn't happen every time. It's when it occurs, you can't solve it. And it's these latent errors of how when care is being provided, the facility to escalate and rescue is not there because there's blocks to it. They will never notice that until it's required. The important thing about safety scientists is you look to see what these problems are and make sure that the safety nets are there before they're required.
Well, thank you so much, Professor Walker, looking at the crisis on NHS maternity care. And this is GB News Originals. Please don't forget to like and subscribe below and download the GB News app, available now in the App Store. Hopefully we'll follow up with you again, Professor Walker, but it's been fascinating to talk to you. Thank you so much. Thank you for joining us.
Okay, thank you.